Preeclampsia is an exclusively pregnancy-related condition defined by a systolic blood pressure greater than or equal to 140 mm of mercury or a diastolic blood pressure greater than or equal to 90 mm of mercury, associated with significant proteinuria greater than or equal to 0.3 grams per 24 hours or 1+ on urine dipstick, occurring after 20 weeks of amenorrhea. This condition often presents as hypertension in the third trimester in a primiparous woman with no prior vascular or renal history, and it tends to resolve after delivery. Currently, preeclampsia is considered an endothelial disease of placental origin involving systemic vascular dysfunction. One of the major characteristics of preeclampsia is its unpredictability, both in its onset and its progression, making it a particularly feared condition in obstetrics. Placentation is a process that begins in the first trimester of pregnancy and intensifies during the second trimester. It ensures the harmonious development of uterine vascularization, guaranteeing adequate placental perfusion for the proper progression of pregnancy. From the second trimester onward, trophoblastic villi gradually invade the uterine wall, reaching the spiral arteries, and their remodeling extends up to the inner third of the myometrium. This leads to the disappearance of the musculoelastic fibers in the arterial media and a significant dilation of their diameter, allowing optimal blood flow. Additionally, there is an increased insensitivity to vasopressive substances, thus preventing inappropriate vasoconstriction. In pregnant women, several physiological adaptations help maintain high uterine perfusion. Uterine vessels are widely dilated to meet the growing oxygen and nutrient demands, increased cardiac output and heart rate to ensure better placental and fetal blood supply. Although cardiac output increases, blood pressure remains low thanks to a carefully maintained balance between vasodilator substances and vasoconstrictor substances. These mechanisms allow for a gradual and stable increase in uterine perfusion, which is essential to support fetal growth and development. In the case of a defect in this process, as seen in preeclampsia, trophoblastic invasion is incomplete, leading to major complications associated with inadequate placental perfusion. Preeclampsia results from an abnormal trophoblastic invasion of the uterine spiral arteries, which compromises their normal physiological transformation into large, low-resistance vessels that are insensitive to vasopressor substances. In other words, the spiral arteries, which are normally remodeled during pregnancy to become low-resistance structures, remain narrow and sensitive to vasopressive substances. This defect in transformation leads to insufficient placental perfusion with reduced placental blood flow. Insufficient placental perfusion causes chronic placental ischemia, which triggers a series of pathophysiological mechanisms. First, it leads to the release of anti-angiogenic factors, oxidative stress, and systemic inflammation, causing endothelial damage. These lesions in turn activate coagulation and promote the formation of microthrombi, small blood clots. This cascade of events has major maternal consequences. Generalized endothelial damage causes arterial hypertension, initially a compensatory mechanism to maintain uteroplacental blood flow, but it becomes harmful when blood pressure exceeds physiological limits. At the same time, thrombotic microangiopathy develops, affecting vital organs such as the kidneys, liver, and brain. This process also leads to coagulation disorders, increasing the risk of disseminated intravascular coagulation, in which blood clots form in small vessels and disrupt circulation. Placental ischemia significantly compromises fetal health. Primarily, it leads to intrauterine growth restriction due to chronic placental hypoperfusion, inadequate blood circulation in the placenta. Reduced fetal renal blood flow causes oligohydramnios, characterized by an insufficient amount of amniotic fluid. Placental ischemia can also result in hypoxia, lack of oxygen, and acidosis, excess accumulation of acids, which disturb the fetal heart rate and in severe cases may lead to intrauterine fetal death. Thanks for watching until the end, and don't forget to like and subscribe for more videos.